Good evening and welcome to tonight's Men's Health webinar with Dr. Damon Deich. Tonight, we'll discuss the signs, symptoms, and treatment options for erectile dysfunction, ED, and stress urinary incontinence. You're invited to ask questions anytime. You can do this by going to the chat function located at the bottom of your screen, or if you're using a cell phone, it will be on the side if you tap your screen. Type your question in, hit submit, and we will answer that question at the conclusion of the webinar. You will also hear from a patient at the end of the presentation. But without further delay, I'd like to introduce Dr. Deich.
Thank you, everybody, for coming out. It sounds like a pretty good turnout tonight, especially after a holiday weekend. Thanks for joining us tonight. So we're going to talk about a couple of men's health issues, specifically erectile dysfunction, which we'll start with first, and then male incontinence, and I'll touch on both types of incontinence as well with men. So first, there's a couple of slides. If you in particular want to learn more about ED, if you have a smartphone camera option, basically you just act like you're going to take a picture of this QR code on the right here, and it will bring up a little icon, and you just touch it with your finger, and that will give you some links to some videos, some of which you we'll see in this presentation too, but that's your primary interest. Either snap a quick picture of that or go ahead and load it on your phone right now. I'll just give people a couple of seconds to do that for ED, and then I'll have a separate one coming up next for incontinence. Okay, so here's the QR code for incontinence. Again, just pull up your camera and point it at that little block picture on the right, and it will bring up the link to the web videos. Okay, if you guys need more time on that, just somebody ask a question and we'll rewind and go back to those. You guys can load those at the end of the presentation if people didn't get a chance. So I'm going to go ahead and continue here. So for those of you that don't know me, I'm Damon Deich. I'm on staff at McFarland Clinic, Department of Urology. I've been on staff for 11 years now. Offices in Ames and Marshalltown, and our phone number is here listed. I'm born and bred in Iowa. I did undergrad in medical school, both at the University of Iowa. I did residency in Detroit, survived that for 6 years and came back. And I've been in town here in Ames for 11 years since I graduated. I'm a part of the Iowa Urological Society that meets annually in Iowa City and pretty involved with them. The American Urologic Association is our parent organization for urology, and the Iowa Medical Society is a statewide run physician oriented support group. I was on the board of Medical Society for the past 3 years. So let's start with erectile dysfunction. Again, you can ask questions anytime, but we'll answer them at the end just so we can keep things moving. So erectile dysfunction is defined as basically the strict definition is basically if it's not adequate for intercourse. If you don't feel happy with the sexual function, then that's what we call erectile dysfunction. And it's extremely common. About 20% of men over the age of 20 and as high as half of men, 50% of men over the age of 40. Almost 40 million men in the United States have this problem. As far as what actually happens with erection, so what's kind of backwards is that you actually have to have relaxation to develop an erection. When your nerves are aroused, they release chemicals that then cause the smooth muscle to relax, and blood flows into the penis. That blood flow then constricts the outflow or the veins of the drainage veins of the penis called the dorsal vein. And that traps the blood supply in the penis to maintain the erection. We'll talk about how the inflow and the outflow are both important in terms of disease states for ED. So basically, I'll touch on a couple of things here, but think of erectile dysfunction as a vascular disease. It has very close correlation with people that have vascular disorder, diabetes, which can affect the vasculature, as well as medications. A lot of times are for hypertension, heart disease, those sort of things specifically can really affect people's erectile function. Unfortunately, I cause a lot of this as a provider when I do treatments for prostates, prostatectomy for prostate cancer, and even with radiation treatments. A lot of times people are developing ED, and so I'm working with patients to rehabilitate that quality of life aspect for them. And then the other way of looking at ED is that it might be a precursor. You could actually have an increased risk of developing major problems such as heart disease, diabetes down the line if you have erectile dysfunction. And I'll show why that is in a later slide. So just starting with diabetes, 15 million people nationwide affected with diabetes. And what's interesting is that they are less likely to respond to specifically oral medications. They're more likely to have severe ED and a reduced quality of life. So diabetes is basically a two-hit hypothesis. It basically can affect the nerves and the vasculature. So you've probably heard of people having diabetic neuropathy where they have, loss of sensory in their foot or difficulty walking. And that's present in up to 60 to 70% of people with diabetes. It also affects the linings of the arteries. It actually increases your risk for arterial damage. And that's why, pills typically aren't enough for a lot of patients that have diabetes. So these are the main causes for ED. Advancing age, of course, is probably the most common. Not so much that you have diabetes, but how long you've had it. So a lot of times I'll say, how long have you been diabetic? And if somebody's been diabetic since, their early 20s and they have 10, 20 years of diabetes already progression, a lot of times you can already have damage already done. There's also a big difference between somebody that's in good control and somebody that's not in bad control. If you are diabetic, we talk about things like hemoglobin A1C levels. Those give you a diabetic level over the past 3 months. And if your level is pretty good, if you're like 6 to 7, then it's almost like you don't have diabetes in terms of your risk factor. But if it's terrible control, 10 to 13, you're going to have really bad problems with ED and probably bad vasculature, increased risk for heart attack, stroke, and those sort of problems. So just touch on the association with heart disease. Again, think of erectile dysfunction as a vascular problem. ED is actually a risk factor for heart attack, stroke, all those sort of problems. And a lot of times it's an earlier symptom and predates problems by usually 2 to 3 years. So if you have ED, you also need to, talk to your primary care doctor about heart health, and maybe even see a cardiologist to make sure there's no underlying pathology. And this is why these obviously aren't to scale, but it gives you an idea that the difference in arterial size is very important in terms of blocking that. You can develop ED problems or flow issues when you block about 50% of the blood vessel, and you see that the penile artery is much smaller than the arteries to your heart and internal carotid arteries that would be involved with stroke, and femoral arteries for vascular disease. So smaller arteries, it makes sense, are going to clog first, and that's why people typically have ED problems before a heart attack or stroke. So there's ways of reducing your risk, but once you've already done the damage, a lot of times it's not reversible. So people always ask, they say, I don't want to take pills, I just want it to be normal. And unfortunately, that's not going to happen. There's no diet that's going to just make your ED go away. But certainly anything that essentially is going to prevent a heart attack is going to prevent ED, at least from getting worse. I mean, if you have some problems, but you're able to get by on medications, you don't want to get to the point where pills don't work. So again, a low cholesterol diet, low fat diet, just like your heart, being physically active, trying to get exercise half an hour of exercise 3 times a week, weight loss, quit smoking, reduce stress, just like a heart attack prevention. Regarding low testosterone, I typically tell patients that testosterone is not a medication that I prescribe for ED, but it certainly augments things. I have had rarely some patients who were on pills such as Viagra type pills. We were able to optimize their testosterone and they actually didn't need the pills anymore. So it can get people functional even without medication. And it certainly plays a part in terms of having success with medication and other treatment options. Low testosterone, there's again 2 sides of the coin here. It's more common with diabetics, obese patients, high blood pressure, high cholesterol, prostate disease, COPD. But the other side of the coin is that low testosterone causes obesity, diabetes, high blood pressure, high cholesterol. So it's not that these problems cause low testosterone. It's probably more likely that the testosterone is causing those issues. And very common, about 40% of patients over the age of 45. And on average, typically I tell patients that your testosterone overall will go down about 3% a year, which certainly adds up. So options, basic options, and I'll talk about a pellet therapy next too. Testosterone gels, patches, oral medications, and injections. Pretty much you don't want to do any oral medications, and I'll touch on that as well. Let me go back here. Oral medications are digested and go through the liver. So a lot of these Nugenics and GNC type oral medications are precursors that they're hoping if they just give you a high enough precursor, it'll be essentially digested and increase your testosterone level. And a lot of the oral medications that are, over the counter or marketed, essentially have been shown in studies by the FDA that they don't actually increase your testosterone level and that those claims are false. What can increase your testosterone is taking oral testosterone. And that is what is actually associated with liver failure and liver cancers because it disrupts the liver function. So pretty much the only safe way of administering testosterone is to bypass the liver. And that's either some sort of topical, whether that's a gel or a patch, or some sort of injection to inject it straight into the body, usually intramuscular. A newer technique that I am trained in now at this point is something called biologic testosterone pellets, which I'm pretty excited about. Biologic testosterone, if you look at these 2 molecules on the bottom, the real testosterone is on the left side, and the right side, you see that there's just like this added little ring on top of the normal testosterone. And that's the difference between testosterone on your left and testosterone cyprinate on the right. And so what pharmaceutical companies do is they take a molecule that they want to patent, and they basically add a little side chain to it, and then it becomes theirs. They patent it and they sell it. Adding those side chains, though, can cause problems that a lot of patients may not want, such as increasing risk for blood clots and those sort of things. So what biologic testosterone means is that you actually have that chain of 4 different rings that's created from a soy steroid molecule, a plant-based molecule. And then the necessary chains are added to it to create a biologically identical testosterone to what you normally have in your body, which of course is tolerated much better than some foreign chemical that is produced in a lab. The nice thing about this is that unlike a depot that's released slowly over a constant dose over 6 months, this is activated by cardiac output, which means when you need it, it gives you more. When you're sedentary and you're sitting on the couch, it gives you less. So that allows this to last for 5 to 6 months, typically 6 months in most men. Testosterone, as we just read about, does, if you have normal testosterone or high normal testosterone, will actually lower your risk for heart disease. It lowers your risk for dementia, prostate cancer, osteoporosis, diabetes, and of course, erectile dysfunction. So how do I cause prostate cancer, ED from prostate cancer? If you look at the pictures on the right, you see that prostate lives between the bladder and the urethra. And what we're literally doing is removing that whole gland and sewing the urethra tube back to the bladder. Well, the urethral sphincter is right past that area. You can imagine by pulling on that area and traumatizing that you can cause urinary incontinence, which of course we'll touch on next. The two yellow pathways on the side are the nerve supply that you try to preserve by peeling the nerve off the prostate gland during surgery. And this is where we get our side effects that affect quality of life. Extremely common. I typically quote probably about 50% of patients. I tell patients 50% chance that after prostate surgery, you're going to achieve similar response to what you have now with medications. So people that aren't even using medications typically are going to be medication dependent after surgery. And I usually tell them that about 50% of patients, medications pill form will not even be enough. And so a lot of these patients are doing injections or going on to surgical correction. I usually tell patients it can take up to 2 years to regenerate the nerve tissue that helps with erection function. And a lot of times, if patients are really frustrated early on, we can go ahead and intervene. I would say at least a year of healing is pretty standard before surgical options are offered. It also can affect ED with radiation. It's not just because of prostate surgery. Again, about 50% of patients can develop ED issues after radiation or prostate surgery. Just want to touch a little bit. So Peyronie's disease is a disease of the outflow of the penis. And what happens is you have those veins that are normally constricted when the penis becomes erect. It's supposed to compress those veins so that you don't have what's called venous leak or blood flow out of the penis. And what happens is these plaques form that are a combination between protein and calcium. And those plaques basically stent open the veins so that you can achieve an erection. You can get the blood flow in, but then it leaks out too quick. And so you can't sustain the erection. In terms of the ability to get an erection, a lot of times, typically it's curved towards the patient. Sometimes it's pretty minor. Sometimes it's so acute that the patient can't even have adequate intercourse where they're unable to penetrate because of the curvature. It can also be painful, especially when you have an erection, kind of an aching pain in the penile area. Treatments are basically targeted to those two things, either the fibrous plaque or the calcium buildup. There's two types of injection, one that works on the protein aspect, one that's targeted towards the calcium. Xiaflex is the FDA approved medication to break up the protein component of the plaque. That is extremely expensive. That's why they have TV commercials. Patients are typically pretty interested in that until I tell them it's about $26,000 for the therapy. And you can imagine insurance isn't too happy about paying for it. So for that reason, I don't do that injection. And I can tell you providers, even at the University of Iowa, aren't too excited about doing it. We do calcium injections in the office using a medication called verapamil, which comparatively costs $40, and patients tend to do very well with those plaque injections of verapamil. You can also do surgery. Not a great option for surgery. Basically, you're either shortening the opposite side, which overall is going to decrease your penile length, or you can excise the plaque and put a graft where that's at, and sometimes that can damage the sensory nerves of the penis. The one fix for both ED and Peyronie's disease, so if you have erectile dysfunction and curvature, the best treatment is what's called a penile implant, which we'll get to at the end, that you can correct both problems with one surgery. So these therapies, I get asked probably 3 times a day about acoustic wave therapy or, some sort of sound therapy to the penile shaft that I heard it works great on everybody. I do use shock wave therapy or acoustic wave therapy to treat kidney stones, and that's FDA approved, and we do that all the time. But as of yet, it's not an approved therapy, which means it's not covered by insurance, which means the studies aren't really supportive of that as a technology. And the patients that are telling me about this therapy were quoted somewhere between $6,000 and $9,000 out of pocket, not covered by insurance, essentially with no guarantee. Because I got so many questions about it, I actually looked through a fair amount of data on it, and there is a lot of data, regarding the technology. The problem is that the outcomes that I'm reading are, in most studies, are very short-lived. They're talking about a 4-month improvement. They specifically, the longest study I could find was 2 years, and pretty much anybody that had diabetes or anybody that had prostate cancer surgery didn't work for those people. Other people that might have had a short, 4-month improvement of their ED, but you got to ask yourself if that's really worth the $6,000 to $9,000. If you think about it, the penile arteries that are inside of the penis, if you treat those, you're still not treating the artery that goes from the base of the penis all the way to the pelvic blood supply. So you're only treating about half of the vasculature. So maybe someday, if we're able to treat the entire vascular length, you might have a prolonged improvement, or maybe some sort of series once it's covered by insurance. But please don't ask me about this in clinic, because I waste a lot of time talking about it. Intracavernosal stem cell therapy and platelet-rich plasma therapy. I did a course recently where they were talking about platelet-rich plasma therapy, basically injecting it in all places of the body, everything from, injection facelifts in women to orgasmic injections in men and women. As of yet, it's extremely investigational to use it for Peyronie's disease, and not covered by insurance, of course. So these are the options that are FDA approved, and I'll touch about these individually. Oral medications, everybody's heard of Viagra. We'll go through that. There's a medication that you can either inject into the side of the penis or put as a suppository pill inside the urethra. That's actually the same medication. There's a vacuum-assisted device and penile implant. So regarding medications, what they actually do is it inhibits the breakdown of nitrous oxide, which is a relaxing agent. And so therefore you're able to get that blood flow into the penis. It is very effective, at least starting out. 60 to 80% of patients will respond to this. And some of the medications that we'll touch on can be affected by food, specifically Viagra, which people don't seem to know that. If you take Viagra after eating supper, it's probably not going to work very well. Side effects, pretty common. I'm hearing headache, flushing, upset stomach, nausea. And there are some interactions with medications. Specifically, every guy is on Flomax. Flomax is an alpha blocker. Technically, you should wait 4 hours between taking an alpha blocker, which is either a blood pressure or urinary medication, and taking your Viagra product. Also, it's a contraindication for nitrates. That means nitroglycerin. Like if you have chest pain problems and your doctor has prescribed that. I have tons of patients that are prescribed those medications, and they're on their medical list. And when I try to prescribe Viagra, it says, "Oh, the patient's on a nitrate," and the computer stops the prescription. And then I talk to the patient, and they always say, "Oh, I've never taken it." And then I say, "Where is the medication?" And they say, "It's in my pocket right here." So if somebody is physically carrying the medication on them for their chest pain, I will not prescribe a medication. I will not prescribe Viagra type medication. If they literally have never taken it and it was just prescribed after like a heart surgery, and they're comfortable with me doing so, I usually just take it off their list and go ahead and prescribe the medication. So as far as injection therapy, now, when I talk to patients about this, initially it sounds like that's something that somebody can't do, but it's very well tolerated. I teach patients how to do this in the office, and I would say the vast majority of people are surprised that it's such a small needle and injection, and that it really doesn't hurt too terribly. It certainly does work. I've seen people that have no response to pills that get a functional erection with injections, and this is probably my go-to if somebody has tried pills after prostate surgery and they really don't want to wait that year or two to get erection function back. or have surgery. And so, a lot of times I'll say, well, let's try injections to get you functional now. And then, maybe we can get you back on pills in the future. I have had 2 patients now that I've taught how to do this self-injection and have developed what's called priapism. So as you go up on these medications, as you go from pills to self-injection, the risk of having an erection that lasts longer than 4 hours, which we consider an emergency, is higher. There's a lot of people that drop out of this. I think at first people are encouraged that it does work and they can see that response. And then, there's a lot of people that kind of fall out of favor with it just because they're having to inject themselves when they otherwise would rather be relaxed and excited. Vacuum assisted device. This is very popular in my VA patients because apparently the VA actually covers it. To some degree, it does work on everybody. Basically, it's a mechanical device that draws blood into the penis, and then you're able to slide a constriction band back off the tube onto the penile shaft, and that kind of just traps the blood into the penis. This is actually great for people that have Peyronie's disease. If you do have some curvature, but it's adequate for intercourse, you can stop your venous leak by putting this band at the base of the penis. Maybe you need the vacuum, maybe you don't. The problem with the vacuum that I typically hear is that, the band kind of blocks your ejaculation. So it kind of, at the height of your climax, it's just kind of uncomfortable for patients. It's also causing a cold erection. You have this blood that's trapped into the penis that basically is not being let out. Going on to urethral suppository. Again, this is the same medication as the injection medication. You're just putting in pill form inside of the urethra. I think I prescribed this twice in 11 years. Not very popular, somehow less popular than injecting yourself with a needle, but it does have its place. It does work. I believe those patients did not get it covered by insurance. It does work pretty quick, 5 to 10 minutes, pretty similar to the injection. The pill starts working. The trade product of this is called Muse, and there's different levels, usually starting low again, so you don't develop priapism, and it can go up very high levels till somebody's happy and functional. Finally, the penile implant is kind of the gold standard for fixing the problem. This is a picture on the right here of what's called a 3-piece penile prosthesis, and I'll go through the different parts here in a second. Basically, what you do is you squeeze this pump. That's how I describe, kind of like a third testicle. It's down the scrotum, feels just like a testicle, and you pump the fluid from the reservoir, which lives behind your pubic bone, and the fluid goes into the what's called the corporal shaft, where these 2 cylinders inflate with the fluid. What's nice about this is that patients usually are very happy in terms of their satisfaction level after they have this procedure for a number of reasons. First of all, it always works when you need it. And second of all, it stays up as long as you want it to, or your partner wants it to, and then you can take it down. So some patients that might have had premature ejaculation before they had ED, this essentially negates that problem where you're not going to lose the erection before, after you ejaculate. I usually tell patients that this is kind of like a car in terms of it is a machine, it can break, but this is not a new technology. It's been around almost 40, 50 years at this point. So it's extremely reliable. The failure rate I usually quote is about 3% each year that some part of it, like the pump or the pump could break, or like there could be a fluid leak or something like that. But most patients are getting 10 to 12 years of good function out of these devices before they need to be repaired or replaced. Quote at the bottom says 7 years, 94% still working. So the difference, there's 3 different types of penile implants. The malleable is basically completely static. There's really no moving parts to it. It just lives there. It is what we call a semi-rigid device, which means it's going to look the same whether you point it down or you point it up and you actually manipulate the penis into the position that you want it to be. It certainly has its place, not as popular. The 2-piece, last company that was making that was called Ambicor. The benefit of this is it's a little bit simpler for a urologist to put in, but certainly that shouldn't be the reason why a patient chooses it. Typically, you're not going to get as good of a cosmetic result in terms of filling the cavernosal cylinders with fluid because basically there's no reservoir. You don't get as much inflation as you would with a three-piece. And then finally, on the left side, you have the bag of fluid up there. That's the bladder behind the pubic bone, the pump down in the scrotum, and then the two corporal cylinders that fill with the fluid. So as far as benefits, it is the most similar to a natural erection. So first of all, nobody besides maybe a urologist in the shower would be able to tell you have this in there. Everybody would just see normal anatomy. The benefit is, again, that you can, when you pump it, it not only becomes erect, depending on which device you have placed in, can actually expand in girth or width and also in length in terms of the number of pumps that you're able to place. The main thing that I get concerned about with penile implant is infection. There is about a 2.5% risk of infection with these patients, and that rate actually doubles if you're diabetic. It now has a coating on it, which is an antibiotic coating, and that actually has reduced the infection rate. Hey, Mike, do you have a video that you can show these guys?
Yep, pulling up right now.
So I think we can maybe let this cycle a couple of times, but basically that's the pump there between two fingers. He's pumping the fluid from the reservoir, if you follow those arrows, coming down and into the corporal shaft. And then when you're ready to cause the erection to go down, there's a release button on top. And sometimes you can actually kind of squeeze the head of the penis or the shaft of the penis, and the fluid will go back into the reservoir. Do you want to show that one more time?
Yep.
Again, exteriorly, you cannot tell that somebody has one of these in. So as you see, the tips of the device don't actually go all the way to the end of the penis. So you do still kind of have a soft head of the penis, unless you're taking Viagra or something on top of that. But it certainly is a good erection for most patients. Okay, so I got to get back to my screen. Okay. Are we back, Mike?
Yep.
Okay. So I typically keep every patient overnight. I just feel like, it's a although it's a small incision site, it's, an uncomfortable area. I typically just have somebody have a catheter in just through the evening, and then I take the catheter out the next morning. Typically, since there's really no risk for hernia in this type of operation, patients are able to get back to work relatively quickly, kind of depending on what type of work they do. If it's desk type work, typically they can go back to work essentially, the following week. If they do more heavy construction type work, they might need a couple weeks off. Typically, we tell patients, although you can start pumping it and expanding the corporal cylinders and that sort of thing in terms of maintaining length, the typical delay is about 1 month. I usually tell patients before you actually use it with sex. What's nice is that typically all of the surgical options for ED are covered by insurance to some degree, at least, depending on your copay and those sort of things. But even Medicare, Medicaid, it's a covered operation currently. So basically the benefits of a penile implant is that you have, 30, 40 years of data. Typically patients are getting 10 to 12 years of therapy out of this before something has to be fixed or repaired. Affordable in terms of being covered by insurance. And again, it looks very natural externally. I think a lot of patients also like that it's just there when you need it. And when the mood strikes, you're not having to inject yourself or do a vacuum assisted device. Possible risks, again, the main one that we get worried about is infection risk. Unfortunately, since this is a foreign body, the whole thing needs to be removed if it's infected. And that's, of course, very frustrating for patients. Again, twice as likely to get infection if you're a diabetic. So I do kind of have thresholds in terms of, what I will do and won't do in terms of if somebody doesn't have very good control of their diabetes, I literally will not offer the procedure. I usually like to see the hemoglobin A1C less than 8. I know that currently, typically your primary care doctor likes you to have it between 6 and 7. So we will give a little bit of wiggle room, but if somebody is, hemoglobin A1C of like 10 or 13 to 13, I'm just not going to even offer it. It's just not safe to do that. In terms of penile length, I get tons of questions. People always want to know, will it make my penis longer? The answer is no. You will actually have shortening of your penile length overall because of scar tissue from this procedure. And typically it can be 1 to 2 centimeters in length, which of course length is everything to guys. So typically before surgery, I usually recommend, or at least offer to all patients, the vacuum assisted device that patients will use that before surgery so that they stretch out the penile length so that they have a better outcome and are able to put in a slightly larger device at the time of surgery so that you're actually able to preserve their penile length. And the studies have shown that if you do the vacuum assisted device daily for 30 days before your surgery, will actually stretch out the penile length by 8 millimeters. Now, if you know your metric scale, 8 millimeters is not very big, but if every millimeter matters to you, it might be worth doing. So I certainly offer that to all patients. So ED is a common problem. I'm assuming if you're on the call here, you probably have it. There's a variety of treatment options. I usually tell patients, we can get you functional. It just depends on how far you want to go. Are you willing to do a self-injection? Are you willing to do surgery? We can get you functional again, but of course, there are some risks as you go up the treatment scale. Okay, so we are going to switch topics here to male stress incontinence. And if you're pretty much just here for the ED part, you can kind of tune out, but we'll take questions about ED at the end, which might be kind of informative. So if you don't mind sticking around for another 20 minutes, I'm just going to talk about male stress incontinence. So there are 2 types of incontinence for men and women. And with men, typically the most common is what's called stress incontinence. And what that means is when you cough, lift something heavy, laugh, you will leak urine. And it's not psychological stress, it's physical stress. So movement-related leaking. There is a different type of incontinence called urge incontinence, which is treated completely different. And that's more of an urgency to go to the bathroom. You're urinating too frequently, and a lot of times you'll be leaking on the way to the bathroom. You can't get there in time. And if you have that problem, I fix that too, but that's not really the topic that we're talking about here. So there are a lot of men that have stress incontinence and nobody wants to talk about it. 500,000 men suffer from stress urinary incontinence typically nationwide. So just kind of as a little mini anatomy lesson here, the bladder actually stores the urine and you urinate through the prostate, kind of like urinating through a donut hole. And as we get older, our donut hole grows shut, or the prostate in general grows in size. And that's what typically causes urinary problems. The sphincter muscle that controls the urine is right in front of the prostate. That's, again, why we have issues with urine control after prostate removal surgery. And then once you get past the valve, there's no restriction all the way out to the to as you void. So again, the most common reason why people have stress incontinence in men is because of some sort of surgery that unfortunately I do. So prostate cancer surgery, again, I usually say that when a patient has prostate surgery, that they will have incontinence when the catheter comes out. To some degree, almost all men have it. And then they work on what are called Kegel exercises, which are a rehabilitation exercise to get that urine control back. Typically, I tell patients, I usually quote them that about 5% of patients, typically at 1 year out from surgery, will have leaking so bad that they want to have some sort of surgical correction for that leaking. And that's usually after a whole year of rehabilitation, trying to get the urine control to come back on its own so that they can avoid surgery. But that's a lot of pads, a lot of stress, a lot of sleepless nights for those patients. So I really want to help them if we get to this point and really kind of get them their quality of life back. You can also have stress incontinence from a number of other things that are not prostate cancer related. I do see typically urge incontinence with patients that have neurologic disorders such as Parkinson's disease, probably most common, but also MS, other sort of issues with neuropathic problems. If you have prostate surgery to resect the prostate tissue, not for cancer, but because you have trouble urinating, rarely that can cause incontinence problems as well. I usually quote patients that there's a 1 to 3% risk of me causing incontinence with that type of surgery. So it's certainly rare, but if you do enough of them, it can happen. Again, radiation can cause incontinence. It can damage the sphincter, which lives right next to the prostate, but that's because of radiation trauma as opposed to surgical trauma. And finally, pelvic trauma, usually it requires something major, like a major car accident, is what's going to, break the pelvis, disrupt those supporting tissues and cause incontinence. So again, why does prostate cancer treatment cause this? We do a lot of robotic prostate surgery for men that have prostate cancer. And when we remove that prostate, we're constantly trying to be very gentle with both the urethral sphincter that lives in front of the prostate and the nerves on either side. But despite that, we still have patients that have incontinence issues and need more help with that. Unfortunately, there really is no medication that I can prescribe a patient that's going to help with male stress incontinence. With stress incontinence, it's a lack of support. So with women, we do slings. With men, we do slings, those sort of things. But typically, as patients are coping with, after prostate surgery in particular, a lot of times I see patients and they say, oh, my leaking's a little bit better, but I'm not drinking any fluids. Patients will actually dehydrate themselves because they know if they drink a bunch of fluids, they're going to be leaking urine and be embarrassed. So that's kind of a learned behavior, which is not necessarily good. I also have patients that just become very overactive bladder. They try to urinate every single time they see the restroom with the hope of keeping their bladder so empty that it just won't leak. Pelvic floor physical therapy is somewhat helpful. It doesn't cause any harm. I really don't see a lot of patients that get completely dry from it. But we do have a pelvic floor physical therapist who is very good. And so if that's something you're interested in and have the time to do that, typically it is covered by insurance if you're interested. Kegel exercises is basically just the home physical therapy that you can do. And I typically, at least after prostate surgery, I'm handing out information sheets about how to do Kegel exercises to kind of get that rehabilitated control of the sphincter back. Biofeedback, we actually don't do. That's more using like urodynamic testing while you're training people to do Kegel exercises. So I have lots of patients that are spending lots of money on pads, $100 a month if they're using 5 or 6 pads a day. Sometimes pads aren't enough. They're using diapers or even condom catheters. At the end of the line, we have this clamp thing, which is not very glamorous at all, that basically smashes the urethra and this little foam clamp that kind of helps hold the urine in. What's basically the first treatment option, again, pills are not going to work. You need to fix that support, lack of support to the urethra and bladder. And so a male sling basically is a device that I'll show you a picture here that basically acts kind of like a hammock, and it helps hold the bulb of the urethra in place with the pubic arch, so that way you don't have leaking when you are doing those activities. When you're coughing, sneezing, it kind of helps catch that urethra so you don't leak. It's really high patient satisfaction if done appropriately. This is not great for people that have a lot of leaking. So if I have somebody that might be using like 1 to 2 pads a day, we actually will do what's called a 24-hour pad test and weigh that urine. And typically, if it's less than 400 grams, somebody can do well with a sling. If it's a higher level of leaking, they're probably just not going to be happy. I mean, in general, if patients are using 6 pads a day and they get down to 2, they're still probably not very happy because they want to be dry. But this is what it looks like. This is a mesh product. Basically, it has to be meshed and to be strong enough to hold the tissues statically. There are no biologic tissues that can be used to help resupport the urethra in men. And the procedure is done through what's called the obturator canal, which are those big open holes in the pelvis. And it's basically suspending the urethral bulb area, that's the light purple area, against the pubic arches. So again, gold standard is what's called an artificial urinary sphincter. And I'll again show you pictures here. This is again the most natural. Basically, you're just putting a cuff around the urethra that's acting like a normal sphincter would. It's again a surgical device, a foreign body that's inside of you, that's always there, always working for patients. This is what it looks like. Again, 3 parts, pretty similar to the penile prosthesis in the fact that it has a reservoir, it has a pump in the scrotum, but it's kind of the reverse in terms of how it functions. So the baseline for this is to have fluid in the cuff, which is around the urethra and keeping pressure to keep the urethra closed. The baseline, again, is closed. When you want to urinate, you just pump, usually just 2 or 3 times, this small pump down in the scrotum, and it takes the fluid from the cuff and puts it back in the reservoir. And it usually stays in there from somewhere between 45 and 60 seconds, allows you to urinate, and then it automatically will close again. It will recycle, fluid will go back in the cuff, and it will recycle. So you basically only have to pump to open. Whereas the penile prosthesis was the reverse. Keep in mind that it was down and you needed a pump to develop the erection. So again, the baseline is fluid in the cuff and maintaining continence. So we have another video. Mike, if you could hit that for me.
Yep. Hello. What? That's strange.
Okay, so again, I'll have Mike play this twice. Again, from exterior, you can't tell that a patient has this. For this part, we don't actually have the corpora that where you have the erection. We just have this urethral tube in the head of the penis. You see the yellow cuff at the base there, the pump in the scrotum. Again, you're pumping the fluid from the cuff. Watch the arrows back into the reservoir. And then after 45 to 60 seconds, it closes automatically. So we'll just run through this again here. There is another button on the pump. We basically just tell patients to ignore it. That's kind of for us to lock it open if somebody ever is having surgery or they might need to be catheterized or something along those lines. So it's only one button to push. Okay, so let me get back to sharing my screen. 1 second. I think I'm actually getting the hang of this. Okay, so again, although it says outpatient here, typically I keep people overnight. It's an uncomfortable spot for most patients. This is typically done what's called a penile scrotal approach or a perineal approach. I typically do these through a perineal incision, which is the area of skin between your scrotum and your rectum. Typically when a patient goes home, what's a little bit odd for them is they feel like they're leaking just as bad as when they came. That's because we leave the device deactivated. I usually wait 6 weeks. And the reason why is you want to make sure that you get a good scar, wide open scar capsule for the reservoir, which has the fluid in it. And in order to do that, it has to be deactivated. All the fluid needs to be out of the cuff and in the reservoir. So that heals like that for 6 weeks. And then the happiest visit ever is for the patient to come in and we actually activate the device and show them how to cycle it. Very high success rate with this in terms of patient satisfaction. This is probably one of my favorite surgeries to do on somebody that specifically might have had like an open prostate surgery 10, 20 years ago, and they've just been dealing with this incontinence. And then finally they hear from a friend or they stop by and listen to a webinar where they're just sick of the pad use. And I've had patients that have for 10 years been using 5 or 6 pads a day. And then they finally get it fixed and they can do things, they can spend that money on other things. And it's pretty life-changing for them. And that's why I like doing it. Again, covered by insurance. ED and incontinence surgeries are typically covered. So again, just kind of touching base on these things. The benefits of using an artificial urinary sphincter is that it's always there when you need it. It's always working. It's probably the cheapest option for patients. If you think about it, even if you have a copay, if you're spending, $100 a month on pads, this can be not only improve your quality of life, but also, probably a cheaper option where patients can save tons of money by just fixing the problem. You will not be able to tell somebody has this in, even a urologist. I don't think I'd be able to tell just by looking at somebody, maybe the penile prosthesis, but not the artificial urinary sphincter. So there are risks. Both of these technically are foreign bodies. The artificial urinary sphincter, again, I usually quote about a 2% risk for infection that could require you to remove the entire device, which again is very frustrating for patients. And you can't just remove typically one part. You have to remove all 3 parts. The slings typically, despite what you hear on the commercials and stuff, typically slings do not get infected. There's really not as much mesh infection as all the commercials will talk about. The nice thing about a male sling is that it's there and you don't have to do anything for it. There's no manipulation. There's no pump. It's just there doing what it needs to do. Again, male slings sometimes will not get patients completely dry. Sometimes artificial urinary sphincters won't either. But typically your best in terms of going from high pad use to, as close to dry as possible, the artificial urinary sphincter is definitely going to be the winner there. So in summary, again, medication will not help this problem. Basically a prosthetic device, whether it's made of mesh or it's artificial urinary sphincter, is really what's going to help these patients, and it's a huge quality of life improvement for them. Okay, so that's the end of the 2 subjects, and I think, Mike, do you have a list of questions that you want to go through? Maybe
I think first we'll
hands off of it, or are we going to do Cliff next?
Let's do Cliff, if you don't mind. So
yeah, sure.
Is Cliff Pollock, who's going to take you through his journey with getting and treating ED. Welcome.
Yes, Good evening, everyone. My name is Cliff Pollock. What you're going to hear basically is the journey that I took with my wife from the time I was diagnosed with prostate cancer through the entire time I had erectile dysfunction and through the time I was able to conquer it. When I was 58 years old, I was diagnosed with prostate cancer. And even though it was just one little spot in the prostate, I decided to have the prostate removed. And as a result of that, as you've heard, I developed ED. I did try the pills, and unfortunately, my reaction to the pills was incredibly terrible. I had very, very severe headaches. I had to lay down, could not pick my head up off the pillow. So they changed the pills from Viagra to Levitra to Cialis, same problem all the way through. Pills just did not work. Went from that to an external vacuum device. And the external vacuum device does work. Unfortunately, there are some issues with it. Number one, it's totally not spontaneous. You have to stop whatever you're doing and pump up. And it always seemed that the more excited you were, the longer it took to pump up. Your penis does get cold. It does turn blue. It does not look natural to your partner. And the biggest problem for me was getting the band, the restriction band, not up off the shaft, but over the head of the penis. And after about 3 months, I gave that up and then went into a major, major depression because I had no idea what else was available to fix the ED. Luckily, after 2 years, I did get an invitation to a seminar on ED, and I learned about the other 3 options, the little Muse pellets, the injections, and the artificial implant. And what I ended up doing was getting the penile implant. My wife and I talked about it, went to the doctor, spoke to him for about 45 minutes, and decided that was what was the best thing for us to do. The day after my 60th birthday, I did the second best thing I ever did in my life, and that was get the implant. I had the implant, truthfully, for 14 years. It worked every single time. It never failed. Recovery in the original surgery was very, very unremarkable. They did send me home with, heavy medications, but it ended up that I have a pretty high pain threshold, and Advils took care of it and knocked down the pain and made it very, very easy to live with. I did go back to work after 2 weeks. I had a desk job. At 6 weeks, I did go back to having relations with my wife. I went back to the gym, started working out again, showered with the guys. They had absolutely no idea, like the doc said, that there's anything inside me because everything is totally inside you and you look totally normal. The thing that's nice about the implant is, as my wife has said, if she did not know me before the implant, she would not know that I really had an implant or anything inside me that was not natural, because your erections look natural, your orgasms are natural, and it's just like you're 18 again, and everything is really well and good. So my implant lasted 14 years. 2 years ago, when I was 74, I had the implant replaced, and I have a new one put in. And I've had this one now for 2 years, and I'm happy to say it works like a charm. The thing that's so nice about it is there's nothing you have to do except pump. You don't have to put medication on ice to take with you on trips. You don't have to put it in your luggage. It's there with you wherever you go, and it's there whenever you want to use it. people ask me a bunch of questions. Number one, the main question I get is, what happens when you go through the airport and you go through the X-ray, the metal detector? And the answer is nothing. My knees go off because I have artificial knees. So they pull me over to the corner and they take this wand. And I don't know if you've ever been wanded at the airport, but they take this wand and they run it over your body. And when they run it on the inside of your thighs, up through your crotch, it's silent, nothing. So nobody knows it's there. The other thing people ask me is, well, what about the chances of, a lot of times you have surgeries and implants and you can't get MRIs or scans and things like that. This has absolutely no effect on that. And also has no effect on any kind of urinary issue you might have. If you need a cystoscopy, not a problem. It does not affect any issues whatsoever with urination. I will tell you, excuse me, that one thing I think that's very important is that if you have a partner, that you take the partner with you to see the doctor and discuss this. And the reason I say that is I get a lot of guys that call me and say, my wife really thinks I'm having an affair with somebody and I don't love her anymore and I can't get erections anymore. And that is the farthest thing from the truth. The problem is you can't get an erection because you physically cannot happen. It does not work. And I think when the woman or your partner buys into it, it becomes really a much closer relationship. I know that I didn't really think we lost a lot of, what was I going to say, a lot of intimacy during the 2 years that we really had no intercourse whatsoever. And I learned that after we were able to have intercourse again, that the amount of intimacy we lost was incredible. And the amount of intimacy we got back was incredibly great. And now at 76, my wife's 74. We have a very, very active sex life. And I will say, you know, you don't have to worry about staying up 4 hours. You can stay up 4 hours, 40 days. It doesn't matter. You become the Energizer Bunny. You stay up as long as you like and as long as you'll tolerate it. So at this point, I think I'll just turn it back over to the doc and Mike, and if you have any questions, I'll be happy to answer them.
Thank you, Cliff.
You're welcome, sir.
Mike, do you want to look through questions?
Yeah. So there's a question about how many pumps it takes for the penile implant to be fully inflated.
So it totally depends on the size of the implant. I mean, there's different lengths, of course, that are put in. It also depends on whether or not you have the LGX that extends outwards, or just the girth one. And, sometimes depends on what's best for the patient. But in general, it's definitely more pumps than the artificial urinary sphincter. I think it's typically somewhere between 10 and 15 for most patients. And then I think they try to push a little bit extra to kind of get things going. So I usually try to tell them to try to pump one more time past where you're at to try to see if you can get up to a larger volume, so that the volume that you have in the reservoir is typically a lot more than you need for the penile implant. And so at least when they're starting out right after surgery, I want them to try to expand it as much as possible. And if anything, kind of stretch out that scar tissue. And so I try to have them pump a little bit every single day to try to stretch that out. But I don't know. I mean, how many pumps do you use on yours, Cliff?
Usually anywhere from about, in the beginning, from, like you said, 8 to 15. Towards the end, it was 15 to 25.
Yeah. So that, I'm not sure if do you have an LGX?
Yes, I do.
Yeah. So he's actually probably stretching out his corporal length. And when you had your device exchanged at 14 years, did they put in a larger device?
Yes, they did.
Okay. So
Yes.
he was, by using this LGX technology, he was able to stretch out the corporal length. And then the next time they put one in, he was actually able to have a larger device placed just because it had been a little bit more dilated. So that must have been a nice surprise for you.
Yes, it was.
Okay. Mike, what else we got?
The next question is kind of related to the quote unquote men's health clinics or the Limitless Male Clinic, and
Yeah.
then the therapies they offer, like acoustic wave therapy. You
Yep.
can just give your general thoughts on those.
Well, again, I kind of touched base on this in my talk. So basically, a lot of these clinics are not being run by physicians. A lot of times they're nurse practitioners and such that really don't have the background in these sort of things. And what they're doing is they're actually using a technology. The technology is FDA approved, but the use is not FDA approved. So this is not something that my parent organization of urology says that we should be offering to patients. It certainly has some data. Again, I touched on this earlier, but I've read all the data because I've had patients asking me 2 to 3 times a day about what I thought about it. And there is data to say that there's an 80% salvage rate, which means if you are not seeing response to Viagra, about 80% of those patients can have a benefit from acoustic wave therapy. However, all of the studies that I'm reading are extremely short. They only look at patients for like 3 or 4 months. And this is a technology that's not FDA approved, so they're able to charge patients cash. And I've heard all sorts of numbers, but somewhere around $6,000 to $9,000 out of pocket for something that might help you for 4 months, for me, sounds ridiculous. The longest study I've seen on this technology was 2 years outcome. And basically at that point, it wasn't working at all for anybody that was a known diabetic or had prostate cancer surgery. And most patients did not, were basically had lost the benefit at that 2-year time frame. So I think that what's happening is you are probably helping the dilation of the blood vessels initially by causing this kind of irritation trauma to the vessels. Again, the problem is that they're treating the penile shaft. They're putting this, sound device on the penile shaft. They are not actually treating half of the blood vessel where it goes from the base of the penis down to the pelvic blood supply. And so they're only treating part of the vasculature to the penis. Again, I use sound wave technology in my urology clinic for kidney stones, and it works very well for that, where you target the sound wave into a cone and it's focused on an area that disrupts calcium. So at least in theory, this all makes sense to me. But if you think about it, if this technology really worked, then why aren't they doing it for heart disease and coronary artery disease and all of these other things where you are treating blood vessel problems? Why aren't they using this for stroke? Why aren't they using, like if it really was a long-term improvement in patients, then they wouldn't have to be offering it in non-MD clinics for cash pay because, that's what's basically mandated. Most importantly, they're not offering any guarantees. So, of course, the answer, if you paid your, $6,000 or $9,000 and it works for a couple months and then you have the same problem, when you say, well, what do I do now? They say, well, pay another $6,000 to $9,000 and get more treatments, and you'll get it back. And maybe they'll have more promises. Like if you do it a couple times, then maybe you'll have a longer treatment response. I don't know. But basically, it's gotten to the point where there's so much advertising and so many commercials, and I get asked about it so many times in clinic that, like, literally, it's wasting my time, where I can be offering things that do work for patients. And so it's been a big frustration to me. You can imagine that all the money that's pouring in, patients paying out of pocket cash pay $6,000 to $9,000 for a treatment that's done in the office, that's how they're able to afford all these, TV commercials and these radio commercials. It's on the Dan Patrick show. I hear it constantly. So my advice is don't waste your money.
Now, is there an age limit on getting an implant of either kind?
No, within reason. You do have to be able to pass a pre-op. And, there's some patients that are so sick that they should not have an anesthetic. And if that's the case, you probably shouldn't get a penile implant. Sex may not even be healthy for you. So, if you're at the point of questioning whether or not sex is even going to be safe for yourself, then you probably should not get a penile implant. But I would say that, the vast majority of patients were able to get through a pre-op and surgery without any question. But no, Medicare did not set an age limit.
Okay, now question. How long after a meal should one wait before taking Viagra or any of the other oral medications?
So Viagra is mainly the one that is so sensitive to food intake. And the most popular time to take it is, of course, like Friday night. And so, what happens is you still have food in your stomach. When we do surgery, we tell patients they shouldn't eat for 8 hours because 4 hours after you eat, you still have food in your stomach. So you probably are going to have food in your stomach from the time you eat dinner on Friday till the time you wake up in the morning. So you need to actually take that pill at least an hour before supper on that night. So if you eat dinner at 6, you would take it at 5 o'clock. And timing that is extremely inconvenient. And so that's where you get into other pill options. And probably my favorite to prescribe, and I have no interest in them, is Cialis, which is tadalafil, for a couple of things. First of all, you can take it with or without food. It doesn't matter. So it just takes that out. And the half-life is longer. So if you take a Viagra on a Friday night, it's gone by Saturday. If you take a Cialis, the half-life is such that it will help you for the weekend time frame. So it will help you on a Friday, Saturday, or Sunday. But some people do better with Viagra than they do with Cialis. Some people might get a headache with one or the other and they want to try something else. So, I don't think there's necessarily, you don't have to try every pill before you go on to something else. There's 4 now. And basically I only prescribe ever Viagra and Cialis, just because it's easy to do so. Levitra and Stendra are 2 other ones. At least the Viagra and Cialis, I don't know about Levitra and Stendra, have great discount codes. If you guys are on these medications, you need to go to GoodRx, just like any other prescription, and you just type in your medication, whether it's Cialis or Viagra, and your dose. And what seems to be the cheapest option is almost always Hy-Vee branches. You'll see the huge cost difference between filling your prescription at Walmart or filling your prescription at Hy-Vee or different places. So you, of course, want to print off the cheapest one and take that with you to the pharmacy when you pick up your script.
Okay, now, for somebody who's getting up 4 to 6 times a night or any number of times, is that something they treat with an artificial urinary sphincter or any of the other devices, or is that a different condition entirely?
That's a different condition overall. Waking up at night is called nocturia, or waking up to urinate at night. And a lot of times it's caused by things that have nothing to do with the urinary system. So it's probably the hardest symptom for me to treat because it's not usually urology related. So sleep apnea causes you to wake up at urinate. If you have leg swelling or if you have edema in your legs, a lot of times that will accumulate during the day. You put your legs up and it'll go back to your heart. There's a number of reasons. Atrial fibrillation or cardiac diseases cause urine production at night. So there's a lot of non-urologic reasons why you could have that. The artificial urinary sphincter is only used for leaking, so that would be the wrong direction for you. You want to be able to completely empty your bladder. And so an artificial urinary sphincter is not the right treatment for that. That's typically more, looking at behaviors the patient is doing, avoiding caffeine, alcohol before bed. And then certainly thinking about, is this prostate related? Is the patient not emptying their bladder each time they wake up to urinate? And so there's a lot of things that we can check out to see how best to fix that.
Now, if insurance doesn't cover an implant, is that something that there's a cash pay option for?
There is. I would be pretty surprised if somebody's insurance didn't cover it. I don't think I've ever had an insurance deny it. If you literally have no insurance, I do get a little bit nervous about those situations just because, if somebody's paying, a large amount of money out of pocket, that, if they were to have a problem with that, it then becomes my problem. So I think I feel more comfortable having patients get the surgeries covered by insurance in general. I think if you, are looking at cash pay options, I know at our clinic, we at least do, or our hospital, we have a 30% discount if you pay cash for surgeries. But you got to realize that my portion is extremely small, unfortunately, of the cost of the surgery. Most of your costs are anesthetic costs and hospital charges. So you could be looking at, $20,000 to $30,000 operations. So I definitely would not try to pay for it in pocket if you can avoid that.
It looks like the last question is, will a penile implant affect fertility?
It really shouldn't. I mean, the way I would look at it is it would help fertility in the fact that you're able to penetrate and ejaculate like normal. It really has no problem with that. I recently had a young gentleman. I love being a part of this case just because he really was in quite a bit of distress. He had had a type of cancer surgery with chemotherapy and I don't think he had radiation, but it was surgery and chemotherapy, and basically became impotent at a very young age. And he was, just devastated by this. I think he was in his late 20s. And we went ahead and did a penile implant, and he was able to get that function back. But I think it really should have no effect whatsoever. I mean, you should still have, assuming you still have your prostate and all those parts, you should still have the normal volume of your ejaculate, and there is no disconnection between your reproductive tract and the urinary tract. So you should still be fertile and have babies if you wanted to. Okay.
And there are no further questions at this time. So I want to thank you both for all of your time and the information that you shared tonight, and everyone for attending. If you want to get a hold of you, was the information on the screen the best way to do that?
Okay. Unless we have any other requests, do you want me to put these things back? I can put one out for ED and just kind of leave it on that.
Well, just your contact information is good, but
Okay.
everyone will receive a follow-up email tomorrow with, I believe, a link to your website and
Okay.
contact information.
Great. Okay. Well, thanks for hosting, and Cliff, thanks for coming. I appreciate it.
Welcome.
Have a good night, guys.